I'll just introduce myself. I'm Sonia, librarian from Stickney-Forest View Public Library, and I work in the adult department, and we like to present. We have presenters speak on topics, and obviously we're doing it virtual right now during this time. And I thought it'd be exciting to hear about June's experiences in the ICU. And we are going to, if you're familiar with Zoom, you'll know that if you hover underneath, hover at the bottom of the screen, there's a chat, and you can click chat if you want to type any questions for June. Otherwise, she will take questions, after her like 40 minutes of presentation. She will do some question and answers, but feel free to type a comment at any time. So you don't, if a question comes to mind and you don't want to forget it, you can type it in the chat. So let me know if you don't know how to do the chat. I think if anyone's on their phone, there is also like a chat option, I believe. So just let me know if you're having a problem with that. And we'll wait another minute or two, see if anyone else comes. But feel free to check out our website. You can Google Stickney-Forest View Public Library and see what other presentations we're offering. And book clubs online. Book club's going to be online June 22nd. All right, it's 7:30. We'll just give it 2 more minutes.
Okay, that's fine. Now, how big is your library, Sonia, for those of us that haven't actually been inside of it?
Yeah, it's a nice library, but it's not too big. And we serve about a population of about 8,000. We serve Stickney and Forest View and a lot of people from Berwyn, because we're up at the edge of Berwyn, so we get some Berwyn people, Berwynites from the south end of Berwyn who come over and use our library, and we get some people from Lyons also that we border. And some people from Cicero too.
Okay. So are you part of the interlibrary loan system?
Yeah, we're in the same system as the Oak Park.
Okay.
Yeah, we're in that same system. So, alrighty. So we have 8 people here. All right. June, do you want me to introduce you, or do you want to introduce yourself?
Well, you can go ahead and introduce me, and I'll fill in the blanks from there.
Okay, I want to welcome June Oliver from Oak Park, Illinois. She's been a nurse for a long time, and she currently works at a Chicago area hospital. We're not going to name it here for privacy purposes. The hospital doesn't want it wants to be official right, June, if you were going to do any.
This is sort of an unofficial, just personal sharing.
Yes. And June also, she has 3 kids who are grown up now. And she sings in her church choir and plays piano. And what other hobbies do you like to do, June?
Oh, gardening and biking. Yeah.
Okay. Yeah, I will turn it over to you, and then it's other people, there might be some latecomers who hop on. But okay. Go ahead. I'll turn it over to you.
All right. Well, thanks everybody, for the people I know and the people I don't know. Appreciate you taking time to just spend together here. Sonia actually called me, I don't know, a month ago, 5 weeks ago, something like that, one evening when I was at work in the ICU, and we hadn't actually talked for a while, so I was surprised to get that phone call. And I don't necessarily always answer my phone, but I had it in my back pocket. I was all dressed up in all the PPE, the personal protective equipment and ready to go into a patient's room, and my coworker said, "Your phone is buzzing. Would you just answer it?" I'm like, "Okay." And I answered it, and Sonia, who hasn't seen me or talked to me for a while, was like, "Oh my gosh, is that you?" So yeah, that was an interesting connection. So I will just say by word of overview, what I'd like to just do is kind of share a little bit about myself and the context of why I ended up working in the ICU, which is not my regular work unit, and what that was like for me, some of the challenges that I and other staff in the hospital were facing, in particular, a little bit about the demographics of the patients that we were seeing with COVID illness in the ICU, and then some human connection patient stories with their identity left out, of course. And I will say that the feeling of intensity at the hospital, that disaster mode that we go into, is lessening, for which we are glad. The regular units are seeing a decline in COVID cases, but the units that handle ventilator patients who are critically ill are still pretty full. There's a small decrease, but not a big one. And so there was a point in time where there was a rising sense of urgency as the numbers were climbing and climbing and climbing, where we didn't know if we were going to be able to meet the need. And we did wonder if we were going to run out of ventilators. And the anesthesiologists were called to take their anesthesia machines they use in the OR into the ICU and teach the ICU staff how to run those machines, because they're different machines in case we didn't have enough regular ventilators for patients. We didn't get to that point where we needed to kind of jerry-rig other machinery to do the standard work of ventilating a patient, but there was that growing sense of intensity and wondering, where the shortages would show up and, what we were going to do. And so that is lessening, thankfully. We know we're not done with it, unfortunately. But a little bit about me. I'm actually an advanced practice nurse with pain service. Some of you who know me know that. And as the COVID crisis started to build in Chicago in March, my regular work really started to decline. So I see a lot of patients in the hospital on consult who have either acute pain post-operatively, difficult pain situations, chronic pain that's flared up. And those consults started dropping dramatically as elective surgeries were canceled and just people were not coming to the hospital with good reason, because they didn't want to be exposed to COVID, with some unfortunate consequences for some people who didn't come when they had heart attacks and strokes and serious issues. That's another unintended consequence, different stories of fallout from the COVID crisis. But as my workload decreased, I was like having a half a day of work to do. And then I would say to the administrators, to my director, I'm like, my caseload is really dropping, and I'm hearing all this, from the emails about everything escalating in the ER and the ICU and the other units that were being turned into COVID units. And some of the units, they actually had to have engineering make holes, big holes in the walls to make a negative pressure system. So they had a big noisy machine in these rooms connected to a big like HVAC, what would you say, tubing or whatever, that would then actually push the air from the room out, into the atmosphere. So there was a lot of busyness, a growing sense of concern where we're going to be able to meet this need because it was escalating daily. And I felt like, what am I doing here? So the point of talking about that is just to give you maybe a flavor of what it was like in terms of this intensity that was building, and administrators I know were working overtime and trying to cover so many different facets of, you know, being ready, the ventilators, the negative pressure, the protocols for the hospital, what kind of medications do we need, et cetera, et cetera. You know, they didn't have a lot of time just to think about me. But the truth of it is I did feel restless, and I wanted to be of help and not just, you know, kind of lollygagging around in the middle of a crisis. That's kind of who I am and what my training is. So it did take a few weeks of me going, hello, I don't have that much to do here, guys. What do you want me to do? We went through a few iterations of, they were going to train me to help a respiratory therapist set up ventilators. I'm like, okay. But when I talked to the respiratory therapy, they're like, yeah, we don't really need another person to do that. So there was so many moving parts. It was hard to get communication really clear and specific. After a few weeks of this kind of going around, they didn't really need me in the ER because they were redeploying even primary care physicians whose offices had been closed to the ER to give them some of the less critical patients, since ER wasn't their field. They redeployed some of the residents to round with infectious disease whose caseload was exploding. And so anyway, the end of it was that they said that they would use me in the ICU. I used to be an intensive care nurse for 20 years plus, but that was also 20 years ago, maybe 22 or 23 years ago. So the body hasn't changed, you know. I mean, I get the body. Most of the diseases are still about what they were, but I want to tell you, the equipment has not stayed the same, obviously, and technology has changed. So it was re-entering into a world that had changed quite a bit since, you know, I was actually a staff nurse. So I ended up working basically as a staff nurse in the ICU, because that was where the real need was, the nursing shortage. It just takes more nursing staff to care for COVID patients. Now everybody's in isolation, and I'm going to dress up here a little bit in this equipment so you can see what that looks like. And it just takes time. You know, you have to don all this stuff to go in, do your stuff, take it off, go don, you know, the same protective equipment for somebody else, take it off. So one nurse just can't take care of as many patients when everybody's in isolation. And just another thing about the hospital, to give you that flavor, they did try to keep the COVID people to designated units. That worked for maybe a week, and the numbers were just increasing. And we were kind of in a hot spot, more than some other areas in the Chicagoland area. And so as the numbers increase, you just can't contain them in one unit. So they ended up more or less spreading out to the whole hospital. It was probably 85% of the people we had in the hospital at the peak were COVID patients, with a few smattering of, you know, people who fell and broke their hip or something and had to come to the hospital and weren't happy about being there. Okay, so in this atmosphere of everything changing rapidly, yeah, we were getting daily emails that were different every day, not just in terms of numbers, but how we were supposed to respond to it, and in terms of how we were doing personal protective equipment. Eventually we got into a routine, but the first night I went to ICU, I knew about the masks and the gowns and the gloves, but what wasn't really mandated but was suggested that I forgot about were hats. So I got there to the unit, and I'm like, oh, I don't have a bonnet. I don't have a hair covering, because there was some concern that when you're working suctioning patients and you're aerosolizing respiratory kind of secretions, that this stuff in the room might just land on your hair, and then you touch your hair, and, you know, so on. I said, and do you have any surgical bonnets? Nope, that they were gone, gone, gone. And I'm like, well, what do you suggest I do? You know, because the ICU was really full of COVID patients. And they said, well, get a pillowcase and, you know, put it around your, open it up, put it on your head, and then you kind of tie it in the back. So the first night in the ICU, I wore a pillowcase on my head. And ordinarily I would feel really silly, but everybody had funny looking stuff on their head, so it didn't really matter. And I don't mean to make light of it, but the next night, I decided, here's my shower cap. I honestly took my shower cap to work because I saw people wearing them. And it looks like ridiculous. But I'm telling you that when you're there and everybody's wearing something ridiculous on their head, some people look like they had baker's hats, shower caps, other hat caps, it doesn't matter anymore. You just want your hair covered. So eventually, people started making hats. This is one, which was very helpful. People started making masks. We had people from the community making face shields. I don't know if you can see this, but it's just a plastic mold that somebody's made on their 3D printer with an elastic band, and then it's like an 8.5 by 11 sheet of plastic that snaps on here. Some people in the community made hundreds of them and dropped them off to the hospital because these recommendations for PPE were evolving. We didn't probably come to a steady state in terms of what everybody had, what was recommended till mid-April, I would say. So from the patient perspective, you can imagine, I'll just put these on, here you are in isolation. Everybody that's coming in, you know, has all this stuff on. And here's our famous N95 mask. There are variations on it, but this one's kind of like a little box. Looks like Chinese carryout, but it's really tight. You gotta get it on here like that, get it under your chin, and then get your face shield on top of it, gloves. And what I don't have is a gown. I didn't bring that home, which is, I will tell you, those gowns, although there are different iterations of them, is like wearing body saran wrap. It is hot, it is sticky, it is very uncomfortable. So you're sick in the hospital, and this is what everybody looks like when they come in. I mean, you can't tell one caregiver from another. In fact, we could hardly tell staff one from another because it's just your eyes and maybe your glasses if you wear them. And if somebody changed their hat, like they had a different hat on the next night, I'm like, wait a minute, who are you? You know, we started recognizing each other by our hats. So I think for the patients that were awake, this added to, you know, the stress that they feel. They're separated from their families, they're ill, everybody's dressed up like spacesuits. Not only does it separate you from human contact, you know, but it makes you feel like you're really sick, you know, because everybody looks like they're going to the moon. Those were some of the challenges, you know, that just were part of the whole care situation. Let me see, I'm just looking at my notes. So when I got to the ICU, I think some of my concerns, personal concerns were, so I haven't managed their equipment in the ICU forever, you know, for 20 plus years. So I was afraid that either I'd be given too much responsibility and they'd leave me alone because this was not a time for regular orientation or preceptorship. It's kind of like survival. Or I was afraid they wouldn't trust me and they wouldn't give me anything and I wouldn't, you know, I'd be like useless. So neither of those scenarios played out. And I ended up being the extra pair of RN hands. So I didn't get an exact patient assignment because they worked 12 hours, 7 to 7. I was there 3 to 11:30. So I would go from nurse to nurse to nurse to nurse and say, What can I do to help you? And then go to the next nurse and help and help. So I ended up being really busy, and I didn't get the sit down time that most of the nurses get when they chart, because I didn't have the assignment, I didn't have to chart. But I will just say, I don't know if there's anybody on this call that's actually a nurse, but I was actually somewhat delighted when I learned the new equipment, how much better it was than what I was dealing with 20 plus years ago. So the way they pass medications, they have these computerized machines that, you put in the patient's name, you tap the screen for the medication you want, and it pops out of a drawer like magic. So, I mean, I was like, wow, this is really cool. And in the ICU, these patients were basically sedated, so they're giving medication so they're asleep, pain medication, and then lots of drips for blood pressure support, as well as the ventilator. A lot of them had kidney failure, so they're having another slow dialysis machine. There's a lot of stuff going on. So each patient might have 6 to 8 IV drips plus fluids. And in a unit of 14 beds, some pump was always beeping. And you would go home I would go home after the shift and almost dream, that you get that sound in your head, the beep, 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 between the monitors and the pumps. But I learned how to manage those pumps, so I could, go and help in terms of changing the medications, getting air out of the tubing. And there's a tribute to Ingenuity for the nurses. I really have to hand it to the nurses that were the regulars up there in the ICU. So everybody's in isolation. The doors, there's sliding doors on the ICU rooms, so they have to stay closed. So every patient's got like 8 drips, a dialysis machine, a ventilator. Every time something beeps, you don't really want to have to, gown and glove and put all of this multiple PPE on every time something beeps. So they got a hold of some tubing that we don't usually use up in the ICU, smaller gauge, really long, like made it, probably 6 feet long, so that they could trail it from the patient all the way out the room, under the door. It was small enough you could go under the door when the door is closed, and then this big array of pumps would be out in the hallway. So when the medication beeped, when you needed to hang a new bag or whatever, you could do it in the hallway rather than having to gown up for going into the room. Oh, and another community contribution that was really nice was this little thing, which you're like, what the heck? Anybody know what that is? Okay, well, I will tell you. Another thing that was interesting that took me by surprise, if you're not wearing an N95, that will leave marks on your face, and you have to take it off every now and then and get a brace. Your regular surgical mask has to be put on. If you wear this mask straight for like 3 hours, 4 hours, ears start to hurt. It feels like it's nothing, but it will rub and it will rub until it hurts. So some community smart techie person made these little plastic things, again, a 3D printer, and you can just hook that, whoops, like that. It works better when you got a hat on, but basically it's just on the back so that it doesn't have to rest on your ears. And those little inventions really made a big difference with just the discomfort of all of the PPE that we had to wear. Okay. Another thing that might be of interest in terms of frequent tasks that we did in the ICU is proning people. And I don't know if you've read anything about that, but so obviously people are having respiratory distress with COVID if they get to the ICU, although many of them are also having other organ failure from the virus. But in terms of the lungs, we would turn people onto their stomach. So normally, right, you're laying in the bed on your back. So we would turn them on their stomach to improve ventilation. They're still connected to the machine, which did seem to help some people, not as much as we had hoped. Once you're critically ill, there's not a lot that helps, unfortunately. But you could see, at least temporarily, that their oxygen saturation levels, how much oxygen is getting to the hemoglobin in the blood, would go up, with the idea that a lot of the damage to the lung is happening in the back, because that's how we usually lay, and gravity brings everything, to the back. If you go on your stomach, some of that inflammation and the cellular debris and the fluid will drain from the back down to the front, and give the air cells in the back a little time to recover and work a little bit better with that air exchange, because they can't exchange air and get oxygen if they're filled with fluid and cellular debris. Plus it brings blood down to the front of the lungs that may not have as much damage. So it did seem to help. Now, how, you might ask, do you turn someone onto their stomach when they're not only connected to a lot of IVs, but a breathing tube to the ventilator, and they're completely unconscious, and many of them very large people? So I wondered that myself, and I found out. So we had nurse anesthetists up in the ICU frequently. So basically took 5 people. The nurse anesthetist would be at the head managing the tube, making sure that it didn't come out, because if it does, they're qualified to put it back in. And then 2 people on either side. We would pad up the chest and the belly with pillows. We put these special pressure dressings on the knees, and then a sheet on top of them. So they got a sheet underneath, now a sheet on top with all of the padding, and then you roll them up like a burrito. Okay, and then all the way to one side, halfway up, 90 degrees, and then over. And then position them, so they're better, and we got this foam ring under their head. So once people know how to do it, it works quite well. But I was interested the first time I saw it to see how we would actually do that. Another interesting thing that I noted just in our ICU of the demographics, and this is also out in the literature, although I'm not going to give you numbers and statistics and references. This is really just anecdotal. In our ICU, most of these critically ill COVID patients were men, probably 80%, depending on the day, 70, 80%. A large portion of them were obese, defined by body mass index. I would say 70% maybe had obesity. And yeah, some of them had other health conditions, but some did not. And we, in terms of age, we did probably have 60 to 70% that were over 60, but that still leaves quite a few people that were younger and critically ill. And we had patients in their 20s, 30s, 40s, and 50s. We don't take pediatrics, so I can't even, speak to that. And a high percentage of Hispanic obese males. That was the #1 demographic that I saw for the critically ill patients. The Hispanic might have been because of our location. I don't know. I mean, it's going to take years for all the epidemiology and research to really kind of sort out what that was. We had challenges with just the temperature in the unit because of the hospital having to rearrange the way air flowed to get negative airflow. Sometimes the air conditioning didn't seem to flow in, especially to the ICU unit. And there were some days when the temperature outside got very warm, and inside really it had to be at least 80 degrees in that unit air temperature. And then you put your, saran wrap kind of gown on and your mask and your headgear, and it was pretty miserable. And some of our patients were running fevers of 104 plus. So just the environmental temperature was definitely a challenge sometimes. And in terms of shortages, we heard a lot about, PPE shortages. We ended up having enough gowns. So I have to say that the type of gown changed frequently. So I don't know if they were changing vendors. Some were very poor quality. One that was so thin, I think you held it up to the light. It's like sheer almost. You're wondering how effective that is. And I put one gown on one night, I guess kind of in a hurry because, you got stuff to do, a little bit too enthusiastic, and I ripped the arm right out of it, just putting it on. I'm like, oh, okay. So the thin gowns you have to put on slowly. And we had some other ones that were a little sturdier. What we did run short on were temperature thermometers and probe covers. So the ear thermometer that you use, that's easy. Thermometer covers are gone, and I can't, since I'm not in the purchasing department of the hospital, I can't tell you the details. I just know on the unit they were gone, and so what do we have to replace them? We have patients with fevers, and they're like, I don't know. I mean, some patients ended up with an individual thermometer, electronic one, but that had to stay in their room. Sometimes disappeared, I don't know. And then we ended up with flimsy thermometers that have little dots on them, temp dots you put under the tongue. We ended up forehead thermometers. And there was, I think, one night where I just didn't have thermometer for a patient. So it was kind of the old-fashioned, feel them, they're hot, pack them in ice. The other thing that we were short on is cooling blankets. We didn't have enough machines, cooling machines, so we did the old-fashioned, plastic bags with ice and just packed it around these people that were so hot. Yeah. So just in the little time that I have left to keep just talking to you, let me talk a little bit about some of the human connection and the stories of the patients and the families. And as I said before, separation from family since there's no visitors. For the ICU patient who's unconscious, the real difficulty is for the family. The patient presumably, isn't really aware of that. And, some of our staff were expressing to our chaplains quite a bit of distress about having to take care of patients who were dying alone. It doesn't feel right. And they didn't have time to stay in the room and hold the patient's hand and comfort them when they're dying, whether their patient was conscious or unconscious. So the staff had a certain amount of what we would call moral distress, as well as the families who are watching, from a distance. So the hospital did form something called a comfort team with people who had been redeployed from their regular job, a number of occupational therapists, physical therapists. I joined because even though I was busy in the ICU, I didn't have a specific patient assignment, so I could get away for, short periods of time. And the hospital purchased iPads for every unit. So we would, on the comfort team, help do FaceTimes and Zoom calls with families who were requesting it. And just a few patients in particular that's kind of stand out to me. I had one woman, Sandra. She was a 64-year-old. She actually wasn't a COVID patient. She was COVID negative, but she was chronic wounds in her legs, became very septic and critically ill, and she did end up dying. She had a large family. I learned on that Zoom call, because, I should say parenthetically, the chaplains who would often do a lot of this communication were not allowed in the rooms. That was the protocol because of the concern of preserving personal protective equipment for the caregivers that had to give the physical care. So on occasion, when the chaplains were there, and they weren't there 24/7, the family would request prayer. They're praying, almost shouting, from the doorway, of the room, because they're not allowed to go into the room, which is a very odd situation. So, the family's on the Zoom call, They're asking for the chaplain to pray. The chaplain's at the doorway going, "Dear Lord," you know. I was like, this is pretty bizarre. It's the best that could be done, you know, at that time. But so this lady was dying. I learned also quick crash course in, you know, substitute chaplain, to ask the family before they get on the Zoom call, does everyone understand the condition of the patient? Does everyone know that the patient's unconscious? So apparently my point person in the family had not told the young adult, looked like a 20-year-old something, that grandma was not responsive.
On here,
And when we got on the Zoom call and I would hold it so they could see, you know, their loved one, she got upset with her uncle who initiated the call and said, "You did not tell me that grandma was in a coma." And, you know, she got upset and was crying. And note to myself, make sure to prepare the family in case the family hasn't prepared other family members. Another patient I remembered, there was an 80-year-old couple, so 80 and like 84. The husband, they both had COVID. The husband was recovering and he was actually leaving the hospital. His wife was critically ill and intubated on a ventilator, and he wanted to see her on the Zoom call before he left. And in this case, I didn't have the authority to change the rules, but I would have let him come and see the patient because he already had COVID. But anyway, the rules were the rules, and the people that were enforcing him said he couldn't come in person. So we had to do this call, even though he was just, you know, a few floors away, ready for discharge. And challenges because he didn't have an iPhone and I didn't have Google Duo. And so we finally figured it out. He was able to download Google Duo, and so was I. And so that he got to see his wife. She unfortunately did end up passing away a couple weeks later. I had a 29-year-old whose first name was Christopher, who came in with COVID, originally signed out AMA, came back critically ill. I don't know if it would have made any difference if he would stayed. We found out that he had bilateral stroke in the brain related to COVID as a complication. He was not doing well. I was able to reach his fiance in the Philippines on a Zoom call. So she got to see him one night, and they have a 1-year-old child together. And then, maybe a week later, he did end up passing away with a cardiac. So we would see neurological, cardiac, kidney, all kinds of other organ involvement with COVID. So yeah, they tried to resuscitate him, but it was clear his organs were just shutting down, and he did pass away. It was a large family. They wanted to do a post-mortem Zoom call. So that's when you'd love to have a chaplain, but first of all, they're not allowed in the room, and secondly, this was now midnight and they weren't there. So one of the other comfort team members and I did the Zoom call for the family, and of course, you know, they were very sad and understandable. And I did ask them, I learned to ask the families, you know, what would they like? You know, whether it's post-mortem or whether it's just when they're sick, you know, do they have a faith? Would they like a prayer? Do they want a song? I mean, what do they want? And I found that most patients, families did appreciate and want prayer, but I knew they wouldn't ask me because you wouldn't think of asking a nurse, you know, to that. You would think to ask the chaplain, but the chaplains weren't there. So sometimes as I've worked with the chaplains and from my own faith tradition and history, I'm comfortable praying with people. And so I found that most of them did appreciate that. So and I found that a lot of my comfort team members, the PT, the OT staff or whatever, also, you know, would pray with families. So we offered what we could. We also had a 20-year-old young woman who came in with an overdose. So her admission was not related to COVID, although she was COVID positive, who just had brain damage from the overdose. And so they ended up withdrawing life support. And that was pretty sad. As you can imagine, the family was very distressed, and then to have to do it on a Zoom call. But for them to be able to see us with the patient, to hold their hand, to touch them, while they actually die. I did have one family that I will remember for a long time. It was a maybe 68-year-old gentleman who had had COVID, and had been intubated for 4 weeks or so. And that was pretty typical, and still is, of people that get critically ill with COVID and end up in the ICU, stay there for weeks and weeks and weeks. They don't die soon. It's like they hang on until all the organs just give up, and it might be 4 weeks, it might even be 8 weeks, which is really sad, in that it just seems like a very prolonged struggle before, they find peace actually in death. But anyway, this gentleman was clearly not going to get better. And so the family did opt to withdraw life support, and they wanted to be with him virtually as soon as the tube was taken out. And we never know how long it'll take someone to die. 3 minutes, 3 hours, 3 days, you just don't know. I didn't think it would be long for him because he really didn't have much lung function left. So I got them on Zoom. The respiratory therapist, the nurse went in, they took out the tube. They didn't want to see him take out the tube, so they just wanted to be with him while he died. And so in that case, I gave the iPad to the nurse, and actually in this case, the chaplain did go into the room, even though she wasn't really supposed to. This was a pretty distressed family. And I heard them say to the family, after it took about 5 minutes, he's not breathing, he's gone, he's not with us, he's stopped breathing, he's passed away. And that was, handled as best as it could be handled. So that was about change of shift, 7 o'clock, 2 hours later, 9 o'clock at night. I'm still there, but the people that had handled the end of life call are gone. The daughter calls, an adult daughter, and the charge nurse answers. She says, I'm just calling to see how my dad's doing. And the charge nurse was like, what? She goes, just a moment, and put her on hold, and she goes, did you guys not tell the family that the patient died? So I said, well, let me talk to her, because I had set up the Zoom call and talked with her. And so I said who I was, and I said, so you were on the Zoom call, right? And she says, yes. And I said, and what did you think happened during that time? And she didn't think he had died. So whatever, could have been done differently, I don't know, but I think it was just an illustration that she just couldn't take it in, and not being there and being separated in a virtual world is not quite the same. And so she needed to hear the words, he has died. Somehow it didn't soak in when we said he's not breathing anymore, he's gone. Sometimes we try to be gentle with the words, but in this case, I think she needed the clarity. So I apologize that it wasn't clear, at the time, and asked her what else we could do for her. But that was memorable for me. And on a happier note, though, I did have a FaceTime call with an 81-year-old Russian lady, was one of our few patients who beat the odds. She was intubated, ventilated. She did get what they call convalescent plasma, which is plasma from people who've recovered from COVID, so it has antibodies in it, which has variable success rates. So whether that was what helped her, I don't know. There's just so many unknowns and so many variables, but she got better. And I got to do a FaceTime call with her and her family when she was on the med surg floor after she was improved and off the ventilator. And she didn't speak much English at all, but her family got on the FaceTime and they conversed in Russian, and she started to cry as soon as she saw them. And so they spoke with her maybe 5 minutes, and then they said goodbye, and then she was still crying. So I stayed with her for a while and not speaking Russian, held her hand and sang her one of my favorite hymns, and that's about all I could do for her. And then I think she ended up going home, which is a happy story. But for the critically ill patients, just anecdotally, where I was working, maybe 10% of the people that we see on ventilators actually come off of them. Now and of those 10%, a few go home and seem to be good. A number of them end up with a trach on a ventilator going to a long-term care facility with varying degrees of neurological intactness. So the long-term care facilities that take ventilators are really backlogged now, in large part due to some of these COVID patients. So what the long-term outcome will be from that, I don't know. But overall, I would say that I'm grateful for the experience to be part of helping a very hardworking staff in the middle of a crisis, to kind of see it from the inside out, to be able to help medically as well as hopefully emotionally, spiritually, psychologically, and connecting family and patients. And so I think that's pretty much all I want to say in terms of giving you a flavor of how it was in the ICU for the 6 weeks that I was there. And I'm going to turn it over to Sonia or to you guys and see if you have comments or questions.
Yes, Peggy had a question, but I think you answered it. She said what percentage of patients who were vented ended up recovering, and you said about 10%, right?
Yeah. That's anecdotal. I mean, that's not a scientific study. Yeah.
Yeah, so feel free, all of you, to unmute yourself and ask a question to June if you so have a question. I have a question. Your 3 children, I would be so worried if my mom was, because I know you have a daughter my age, and I thought your oldest one I think is my age, and then I would have just been so, I would have said, Mom, why did you volunteer to go to the ICU? Are they worried about you at all? Or?
Not as much as they should be. A little bit. I don't know. I think they're kind of used to me being independent minded, shall we say, and I was careful when I came home I wore scrubs. This is what I have on now. Those stay at the hospital. So, and my shoes would stay at the hospital. I wash out my hat, every night. So I think I was as careful as I could be. And my son, who still lives with me, we separated towels and, in shared space. So my brother was more worried than my children, who's a doctor, but, I appreciate the concern, but I really felt like it was something that I needed to do and wanted to do. And so I went with that.
Wow, I admire that so much.
Thank you.
So another question, are the people on ventilators always unconscious? And what percentage are awake?
Almost 100% would be unconscious purposely. We put them on sedation because being on a ventilator is uncomfortable. Occasionally, when people are being weaned down and off, they may lighten up the sedation. But these COVID patients were generally so sick, they were all, significantly sedated along with pain medicine on top of that.
Did any of the nurses you worked with or doctors you worked with get COVID, like really bad case of it? Oh, yeah, that's another question.
Right. Yes, some staff did, I can't remember the numbers now. Some staff did get COVID. We did have 2 staff members that died.
Early on, or
But what?
was it early on before, like
One
all the,
was later, one was in May, and one was a little earlier in
wasn't
early
that so
April.
scary for you? If, like, to have,
You know, I don't know what to say, except I think when you're dealing with a situation that you know is potentially life-threatening, but there's a job to be done, you're as careful as you can be and you don't dwell on the risk, or else you wouldn't go into work. You know, I don't know what else to say. I think it's similar to anybody dealing with a risky kind of situation. Well, we did learn some things. I mean, one was men who have beards were at higher risk for for mask failure. One of our fellows who had a beard, so he was in the room intubating people. That means that's a pretty high risk procedure because everything gets aerosolized, put out into the air. And he got COVID. He wasn't critically ill, but he was home feeling crummy for a couple weeks. They said that the mask probably just didn't adhere the way it's supposed to the skin with the beard. There's just enough space there if you're in a highly aerosolized environment that the virus can get in. So he got sick. So after he got sick, all the men with beards shaved. We did have another patient earlier on in March that I was exposed to that we didn't know was COVID for 4 days, and we were still evolving in terms of how we were treating people and what kind of PPE we were wearing all the time. A couple staff did get sick who were exposed to that patient. I did not. I suspect I may have had COVID in March. I had an upper respiratory infection with the cough, but early in March they weren't testing the staff. Like if you weren't critically ill and you weren't particularly short of breath, just stay home. So I don't know. And I forgot what the question was, but people, yes, staff did get sick. Most recovered, thankfully. Let's see, here's a question. Someone admitted with COVID-19, when you're in a condition. How did specialists communicate with each other? What was the stress level like among the staff, and how often were loved ones notified of the patient's status? Specialists communicate with each other the way we always do. We have electronic communication on our cell phones, on a system like an encrypted paging system. We hopefully read each other's notes in the chart. I think the communication was pretty good. Stress level among the staff, I would say up and down. What I saw was, like I said, that moral distress of people not liking that their patients were dying alone and they couldn't do much about it. There was more anxiety about the disease itself earlier on. I think like now we still have COVID patients, but now we feel like we're kind of in a routine. We're not careless, but it doesn't have the same fear level because I think we're in a routine. We know our PPE. We kind of know what to do. How often were loved ones notified the patient's status? I can't say that there was a set time. If there was a change in condition, the physician would call, but often the family would call, you know, and if they requested FaceTime or Zoom, then the nurse would often reach out to someone on that comfort team. So probably, you know, the Zoom calls take time, the FaceTime takes time. We couldn't do them every day. You know, we probably did them every 2 to 3 days for family.
any last questions for June? If not, she will wrap it up. Thank you so much. That was just amazing. Amazing. And again, for those who came in after the start, June is an ICU nurse in the Chicago area, but we're not naming the hospital, or the hospital's request. So, yeah, amazing.
Yeah.
Yeah.
Well, and the hospitals, I'll just close. I mean, hospitals all over the country, have done really an amazing job with a very stressful situation, a big stress on resources. Like many other businesses, they've taken a hit because, that's how they generate income, is through their elective surgeries. So unfortunately, many hospitals have cut positions. Our hospital has opted to decrease our salaries instead of cut positions. And I would say that by and large, staff have kind of accepted it as inevitable. I mean, it's unfortunate that you get to risk your life for less, but it's more than money that drives, most people in healthcare in terms of service. So it's a challenging time for healthcare as a business and certainly as a service, in ways that the whole country is feeling, similar challenges. But the hospital has tried to support morale. I'll just close with this too, and I appreciate this from administrators throughout the last couple months at different times of the night and the day. Couple administrators would come through with a cart with carts of snacks, to the units, treats, sometimes little gifts, water bottles or whatever. And now when we get our temperatures taken when we first come in, as everybody does, they're playing like upbeat music. So it's kind of like you're coming into a little dance hall, when you're coming to work. So it's a little funny, but I appreciate the effort to keep the morale up. And a lot of grade schools and other schools drew pictures and sent them, and they're all plastered on the walls as you walk into the hospital. Thank you, for your service. So I think there's been a lot of sense of gratitude and appreciation, which I think the hospital staff really noticed and appreciated, that their efforts, have certainly not been ignored. And so, that all counts. And so just kind of a general thank you to all people out in the community who have, expressed appreciation to hospital workers. So stay safe, everybody. We're not done with this virus yet.
Yes. Well, thank you everyone for joining.
Thank you. It's very interesting.
Great. All right. Thanks for spending the evening with me.
Let's see.
Bye-bye.
Bye. Let's see. Yes, just comment saying thank you. Well done. Thank you, June. Yeah. Enjoyed hearing you this evening. Very interesting. I'll second that.
Awesome. Well,
Pretty
thanks for inviting me, Sonia.
Sure. Thank you for agreeing.
If you enjoyed this video, please like the video and subscribe to the Stickney-Forest View Public Library's YouTube channel. Also, like and follow us on Facebook, Instagram, and Twitter. The Stickney-Forest View Public Library District, where great things happen.